We now would be, he told us about using it in normal eyes, and I think we have Dr. Gayatri Banerjee from the Nepean Valley Eyes Surgeons, Australia, Sydney again. I think she's working and also experimenting it with patients with some comorbidities. So understanding the presbyopia patient outcomes with refractive PCIOL, all yours, Dr. Gayatri.
Thanks very much. I want to approach this from the viewpoint of the user, which is us, the surgeons. And I just want to highlight some of the points. That's a new type of refractive extended depth of focus lens that offers this continuous power technology. It's on a known platform. It's a hydrophobic acrylic lens, which offers comfort to us because we know the Technis platform already. Professor Roberts already highlighted it. It really does offer refractive accuracy and a good range of vision. So it nails the distance, gives intermediate vision, and some functional near for the modern day life that Professor Manipal was talking about. It also offers rotational stability and ease of delivery, which all matters to us as surgeons. Because what do we want as surgeons? Well, ultimately, we want to meet our patients' expectations. We want less chair time, simple, efficient answers. We want to meet our refractive targets with a well-tolerated lens, a known platform that gives us peace of mind. So what exactly do our patients want? Often they don't know what they want. They want a good range of vision, less dependence on spectacles, but most of our patients don't mind wearing spectacles for, fine reading, very small reading work or reading contracts, so long as they're not dependent on spectacles for everyday activities such as reading newspaper or looking on the phone. Patients don't want to be dealing with too many side effects of lenses. And although we talk to patients in counseling about the concept of trade-off, people don't really like the idea of compromise, and they want a lens that can give them as much as possible with as least trade-off as possible. Ultimately, the measure of success in my practice is that my patients want to see at least as good as their neighbor who recommended them to come and see us. So we've got to set the patient expectations about this concept of trade-off. Clarity is very important, nailing the distance vision, as we mentioned, range of vision, and side effects. And the PureC offers this refracted extended depth of focus technology with this continuous change in power on the posterior surface. And that actually allows a distribution of light from far to near, which allows a greater range of vision. The other key factor is that it's not too much compromise in terms of dysphotopsia. And the dysphotopsia profile is very similar to a monofocal. If you compare multifocals, there's a significant trade-off to be had. The dysphotopsias are forgiving even under the condition of defocus. And so with a plus 0.5 diopter hyperopic error, they still have less dysphotopsias compared to a trifocal or a symphony, and again with a minus 0.5 diopter. An important point is the corrected distance vision, and a point about this lens is that you must use the maximum plus technique, and auto-refraction is not enough because that just uses the central zone to estimate the refraction. So you need to instruct your staff, measure uncorrected distance vision, and then start at plus 0.75 diopters and drop down in minus 0.25 diopter increments to get the best corrected distance vision. The delivery system is our known platform, Simplicity platform, that's preloaded, 3-step process: hydrate, advance, and deliver. And it's easy to insert during surgery, and you don't have to worry about nurses scratching lenses, etc. The rotational stability is achieved with the haptic design, which are squared off and frosted. And in my own real-world experience, I've had no requirement for intraocular lens rotations postoperatively with this lens. My own experience of 91 eyes over a 6-month period, it was a retrospective, non-randomized study in a real-life clinic. We did not exclude mild comorbidities, and we achieved 91% of patients achieving 6 on 7.5 or better for uncorrected distance vision, and 100% of patients achieving 6/9 or better. Intermediate vision, 78% achieved N8 or better. And again, near vision is not promised, but it does provide functional near. We can see the depth of focus. I use aberrometry postoperatively, and can see that it does offer a greater depth of focus compared to a monofocal. I was a heavy user of another non-diffractive extended depth of focus lens, and my impression is that it actually provides that depth of focus without these complaints of halos and glare. And I am a user of mini monovision, and one can see on the PureC image, we can achieve a great range of vision. At this particular patient had a range of 5 diopters with the use of mini monovision in the dominant and non-dominant eye. So it's increasingly taking up the bulk of my practice, becoming the default option. Monofocal lenses are still an important choice for patients, particularly if they've got other severe ocular pathology, ocular surface issues. High myopes, there's still a role, I think, for keeping them myopic. Multifocal lenses are for the patient who's really highly motivated for reading vision and is prepared for the trade-offs. And also, it's a lens in my practice of exclusion. You have to exclude if there's strabismus, large pupils, retinal pathology, severe dry eye, high-angle kappa. The most important exclusion is the personality of the patient, who's got to be able to prepare to accept the glare and halo. So, some real-life studies. This was a fit 65-year-old gentleman who was a company director. He's a keen golfer. He presented with a rapid deterioration in vision, no significant ophthalmic history that he knew about. He presented with a vision of 6 on 9.6 and 6 on 24. And I found on the initial slit lamp examination, he had a significant dry eye with a tear film breakup time of 5 seconds. I treated him with lubricants and hot compresses. I brought him back 6 weeks later. Interestingly, his vision had actually improved to 6/12, just with that alone. And we then proceeded to recheck biometry and proceed to cataract surgery. The outcome was the patient was delighted. He was not noticing halos and glare. His best corrected distance vision was 6 on 4.8 in the right eye and 6/6 in the left eye. Intermediate, 6/12 in the right, 6 on 9.5 in the left. And he can now see his golf ball. So he's a happy patient. Given this early experience, I then started to move on to use this in patients with a wider range of issues. This was an 87-year-old gentleman who initially presented in 2021. He had shallow anterior chambers and cataract, vision of 6 on 48. At the time, I initially performed peripheral iridotomies. I then proceeded to cataract surgery with the iHance intraocular lens implant, using the Hoffer Q formula because he was noted to have a short axial length. Postoperatively, he achieved 6 on 7.5. He could read N12. He was happy, but he thought his near vision could be better. In 2024, he presented with his second eye. Vision had reduced to 6/18. By then, for shorter eyes, I was using the ESCRS multi-formula, and I ended up using the Kane formula for this patient. Postoperatively, he achieved 6/6 unaided and N6 unaided. So he's a very happy patient. Third case, and this is again after achieving a little bit of experience with the lens. It's a patient who had pre-existing pathology, initially presented with proliferative retinopathy and diabetic maculopathy, and significant dry eye. So I treated all of the above with anti-VEGF injections, panretinal photocoagulation, lubricants, and IPL. So once all of this was stabilized, we then proceeded to the POC lens implant. Postoperatively, the patient sees 6/6 and N8 for near. So this is a user-friendly, reliable lens with less trade-off, suitable for a wide range of patients, and delivers a practical range of vision for patients in the real world in a general clinic.